stuff over the weekend. A little bit. Okay. So did you all get the new schedule update from 25 July? How tomorrow it's got me as the lab at 10 instead of master seminar. Master seminar is at 13. Okay. Okay. So how about Dr. Frischioni? It doesn't sound like she has a large amount of information tomorrow, right? So she was trying to do you a solid in that aspect. So she has to be here at 10. Yes, that's not a problem. We'll do the lab portion. What I don't know is ortho actually available? If not, that's fine. We'll still do it, and I'll just run it just like they do. I mean, same concept. It's just me doing it instead of them, but we'll see on that. So that means we have a couple of options. You don't need to decide now. You guys can talk about it as a class. I'll wait for the class leader to text me and let me know as far as the Q&A review goes, okay? Technically today we will be done with lecture, okay? We'll be done. We'll finish this today, and we'll be finished, okay? So the lab is almost like a review. It's going to be kind of going over stuff, naming stuff, looking for abnormalities, that kind of thing. So it's kind of like a mini review in itself, all right? Then we have the actual Q&A portion that I want to offer you guys, okay? If, let me just double check my calendar. Yeah, if you want to do it, like do the lab, take a break to kind of go over stuff, because the lab is or the review is optional. My Q&A is optional, right? Not the lab. So if you want to take a lunch and you want to, if Dr. Fitzy only has nothing or only has a few minutes, and you want to jump on it Tuesday afternoon to do the Q&A then, I'm good with that. Let me know, okay? Looking at your current schedule, if you can't do it there, then let me know if you would rather do it Wednesday afternoon, either after your 1300 ENT is done, or just whenever they're done, basically, is what I'm looking at. If they take the whole time, then it'll be right afterwards. If they don't, they're done early, I can come in early. I just need to know what the class wants to do. Does that make sense? So don't have to decide now, talk to the class leader. I'll wait for them to tell me what the plan is, and we'll go from there. I'd like to do it no later than Wednesday afternoon after that last HE&T block, right? Because I want to give you 2 full nights to kind of absorb and go over stuff. I don't like the idea of Thursday before the test on Friday. So, up to y'all, okay? I am at your mercy. As always, I am available for questions one-on-one if you want. I've gotten a couple of emails in Canvas to set up times. Happy to do that, all right? Questions about last week before we jump into this last lecture block. All right, let's power through. We are now focusing on the lower extremity. All right? So, what do we have here? Not looking for big fancy names on this one. I just want to make sure you see the big distal fibula fracture here. Okay, that's the big shiny toy. Everybody gets excited about that. Don't overlook the extra piece down here at the end of the distal tibia as well. Okay? Kind of hard to see on the lateral view here, but if you follow your fibula bone down, oh, that's supposed to be down here, and then here's that extra piece. Follow your fibula bone down, there's that gap, there's the extra piece hiding behind. This is why we get multiple images, because sometimes fractures are a lot easier to see on one than the other. Okay? That's why you have to use all the images, different images, to look at everything together. Sometimes, especially with Salter Harris, as we kind of talked about a little bit, sometimes remember that the fractures and the stuff involved a little bit easier to see post-reduction, right? Because maybe there's overlap sitting somewhere like in this lateral, and you're like, I can't tell what's bone, what's not bone. But then if it gets reduced and put back to where it's supposed to, and it's anatomically how it should be lined up, you can see fractures a lot easier sometimes. That's what this may look like. So how quickly do you think you should call ortho on this guy? Before the x-rays even come back, right? Like I'm getting x-rays now, but especially if you're in the ER, which this probably is, I'm getting x-rays now. I need you guys to come down here. His foot is bent in a way that feet don't bend, right? It's not supposed to do that. All right, so lower extremity, and then that's it. We're done with bones. Just the lower extremity. All the stuff. And again, we hit a lot of this already, right? We looked at the pelvis. We looked at the hip. We looked at the femur. We looked at some of the foot and ankle stuff. So now we're just going to get some of the specifics, right? Specific disorders, specific types of fractures, show you what it looks like, because we already went over a lot of this, a little bit of a slower pace. So here's your anatomy for the entire lower extremity. Here's the anatomy for the hip joint. Again, I'm not hitting you on muscular stuff, but this is very beneficial for you in clinic when things hurt, when you guys are doing the piriformis test, doing the Overs test, trying to figure out, well, am I doing it right? Well, what's it pulling on? Are you doing it right? Here's your normal radiograph. So I'm just going to kind of brush over this. We looked at it already. Key things, most common things that people get tripped up on when they start learning radiology. We've already hit, I'm going to hit it again. The fovea is normal. That is not a fracture, right? That should look like that. Knowing where your SI joint is, that is not a fracture. Knowing the sacrum comes right into the ilium and there should be an SI joint there. That is not a fracture. Your intertrochanteric crest. Every once in a while, I'll have an x-ray and somebody will see a radio-opaque line and they'll interpret it as a fracture. Fractures are normally what? Radiolucent compared to the surrounding tissue, not radio-opaque, right? So what are radio-opaque lines? Sometimes there's things like this where it's intertrochanteric crest, which is a little bit of extra bone kind of sitting on top of each other. Sometimes there's things called like a nutrient vessel. You don't need to know the detail of it, just know that radio-opaque lines are not fractures. Radiolucent lines are fractures. Okay, so if you weren't sure, like, well, is this bone sitting on top of each other because of a fracture? Go through your stepwise process. Follow your cortex, follow your medullary canal, look at your soft tissue, look at your joint spacing, and see if you see any abnormalities. If you can't see one, then your radio-opaque line is not an abnormality.
Can you also see it bilaterally?
Theoretically, yeah, you can see it bilaterally, but I wouldn't do let's say this person came in, so is this right or left hip? Let's do that one. Left, yeah, we're getting it. All right. So, if someone's going left hip pain, I wouldn't do a right hip just to verify that this radio-opaque line is an intertrochanteric crest, right? There's no reason to give radiation on that side because this is not one of those things that's like, some people have it, some people don't. Everybody has this, it's part of their anatomy, right? And then, not only that, but, what was I going to say on that one? I'm not concerned for the abnormality then because it's not a fracture. So I would not review the other side just for that. Oh, that's what it was, positional, right? So it might look a little bit different just because if that patient is rotated just slightly a little bit and how that bone's superimposed on one another, it could alter that line just a little bit and you'll trick yourself into thinking there's an abnormality when there's really not. So if you know your anatomy, then you won't get tripped up on that guy right there. We talked about this frog leg lateral. Right? This is the lateral of the hip. It's called that frog leg. This one we typically do bilateral, both sides, to just get a better visualization to compare one side to the other. Really what this one is mostly used for is going to be, so this is a normal one, but it's mostly going to be used for evaluating the femoral head, the femoral neck, and this part of the femur here, how it kind of sits in the acetabulum. You can't really evaluate a whole lot of the pelvis on this frog leg, at least around the hip joint, right? There's a lot of noise. It's really thick. There's a lot of bone there. This is primarily used for the articulation, making sure we got a nice lateral femoral head. Notice how I really don't see a whole lot of fovea on this, right? It's nice and round how it should be, sitting in the acetabulum. And I'm looking at the greater trochanter, lesser trochanter, femur. See how all that stuff kind of pops nicely in profile. Again, right here, radio-opaque line, intertrochanteric crest, not abnormality, okay? Femoral neck. Biggest thing is skiffy. That's what we're going to use the lateral hip for. We're going to talk about what skiffy is. There's a very specific patient population for skiffy. This is another one of those things we don't want to miss. Now here's another image of the lateral view. Again, look at how well the joint and the femoral head and the acetabulum kind of come together, and you can really evaluate that. That's really what this is used for. You're still going to go through your stepwise process, right? But know that you still got to look at what you can see on the image, because you're responsible for all of it, but that's not what this view is primarily used for. It's primarily used to look at the femur and the hip joint. CT, what kind of slice? Coronal. Right? No, there's not something wrong with the right leg. It's just the slice that we have. Maybe the patient was lying down and they kind of like this just a little bit, which is why we get one more femur than the other on the slice. If you were to scroll all the way through, you would be able to see the whole thing. MRI, what's the difference between the MRI and the CT? Right? Smoothness, soft tissue, used for labrum, used for things like muscles, spinal cord, that kind of stuff. Not typically used for bone, except for in the settings of avascular necrosis, where that's the study of choice. But that's not because we're necessarily trying to evaluate the bone. We'll see the small fractures, but we're looking for that avascular necrosis. So remember, MRI is a study of choice for any concerns for avascular necrosis. Okay, hip dislocation, just like shoulder dislocation. X-ray is your initial study. What's the most common direction for shoulder dislocations? Anterior. What's the most common for hip? Posterior. Don't get those confused. Okay? So typically, these are really rare, but typically it's going to be high impact activity. Motor vehicle collisions are the most common. All right? It takes quite a bit of force. It takes way more force to dislocate your hip than it does your shoulder. Okay? Way more force for that. The hip joint is way more stable because of the way that the femoral head sits in the acetabulum. On top of that, between the labrum, the ligament teres, that fovea kind of right, connecting all that in there, it's really hard to dislocate that. Which means if you do dislocate your hip, you have probably caused significant damage, right? X-ray is still going to be your initial study. I'll hold off on the posterior anterior dislocation imaging here until we get to the next couple of slides, because it's easier to see it and understand it as opposed to words. But some people like words, so here's words. All right. You don't need an X-ray to determine hip dislocation. It is, here are your two types. If the leg and knee are over and in, okay, that is a posterior hip dislocation. They cannot move it out. If the leg is out like this, that is an anterior hip dislocation. They cannot move it out. The nice part about this is now too, how many X-rays do you think I need to determine the direction of dislocation for the hip? One, unlike the shoulder. Look down here. Where's my femoral head? Because of the position that the patient has to be in based off of the mechanism of action of that dislocation and where the femoral head sits, which is what's driving the direction of the leg with the abnormality, right? The knee is always more medial. Femoral head is sitting more lateral for your posterior hip dislocation, and vice versa for the anterior. I only need this AP view for the hip to determine that what direction is dislocated. I don't need a lateral view. Because could you imagine me trying to ask this patient to do a frog leg and give me a lateral view? Sure, I guess technically in the anterior dislocation they're already there. All right? But try getting a posterior hip dislocation for this person to do that, and that's the most common. You don't need it. Okay? Here's some examples of what they're going to look like. How do I know this is anterior? Because when I look at the picture, my brain tells me that looks posterior at first glance. Which way is my femur going in relationship to my pelvis? Which way is it going, right? Femoral head is going medial. Okay, that's fair, but barely, right? Barely. Use the direction of the femur to determine anterior or posterior, because when I go back, look at where the femur is going. The femur is going out, lateral from that hip in my anterior dislocation, out and lateral. So where we're using the humeral head and shoulder dislocations, the easiest way I think to understand the hip dislocations is use the direction of the femur in the x-ray. Yes, I recognize that you're going to be the one seeing the patient, so you'll know just by looking at them, right? But this is a radiology course and we have to interpret films. So use the direction of the femur. Going back to this one, the femur goes in the direction lateral to the hip joint. So when the femur is going lateral, how do I know it's lateral? Well, here's my pubic symphysis, which is the medial part of the body. And so the femur is going lateral. That's my anterior dislocation. Here's another one. Gives you the patient of how they presented and what the x-ray looks like. Okay? Here's my posterior dislocation. The femur is coming more direct medially. Because again, look at that femoral head. Right, maybe. But if I use the direction of the femur, it's not going way out here. It's not going way out here. It's coming down more medial. I know it's dislocated, right? And so you're going to tell me, well, that's not really that medial. How am I supposed to know that that's kind of a dislocation? It's not really that medial. Well, if you go through your stepwise process, the femoral head is not in the acetabulum where it's supposed to be. And this picture's nice because we have one where it's supposed to be, right? So you're like, okay, I'm probably dislocated. So now my next question is that femur going straight out or not? There is no way, around that anterior except for it to be straight out. So it's extreme, okay? So when we go posterior, it's not straight out like that frog leg lateral in a way, so it's not sitting out like this, so it's a medial of that femur area. So it's a posterior dislocation. You see the different tools to use for this one. I think I have another, no, that's different. Okay. Posterior versus anterior. Just the one image. Follow the direction of the femur and understand for yourself, if you understand your anatomy, right? If it pops anterior, where's it going to go? This is the only place it can comfortably go. Like, you can't really take an anterior hip dislocation and bring it over here because the pelvis is in the way and stopping me from doing that. That's why the leg is stuck in that position. Same thing with the posterior. It pops out behind, follow my knee. I can't do it this way. It's not going to allow that to happen. And most common for hip posterior dislocation, most common for hip dislocation is posterior. Most common for shoulder dislocation is anterior. All right. Big yellow arrow sign. Be honest. Ask yourselves in your head. You don't have to answer to me. If you didn't have the big yellow arrow, would you notice that it was fractured? Would you notice the abnormality? And I don't mean that to sound like condescending or like you see that, but we're at a stage now to where it's different from lecture 1, right? You guys have seen multiple of these throughout the lectures, or Radiopedia, or however you've been studying, right? So I want you to kind of build your own confidence of like, hey, yeah, I can definitely pull that out. I wouldn't know what to call this one except for proximal femur fracture. There's kind of a lot going on here in this one. I mean, it's definitely complete. Is it oblique or maybe? I don't know. Could it be spot? Like, it's too complex to kind of actually name it more like oblique versus spiral. Maybe, you know, yeah, it looks like it could be a little bit shortened, but like, this is a tough one. So like, I just have this labeled in my notes as just proximal femur fracture, right? Which means if I give you something on the exam, right, it'll be clear cut, or the answers will be different enough for you. As long as you know how to describe it, you know what you're looking for, you'll be all right. Yeah. Good eye, right? So I need more pictures, but what he's looking at is the femoral neck here, good for using your normal, right? And then, okay. Where's my femoral neck, right? That's the question. I don't know, right? With just one picture, I don't know. Could it be the fact that it was shortened and then this proximal portion started to rotate a little bit, which is why you kind of don't see the femoral neck? Maybe. right? But you're doing the right thing. You're sitting there going, I'm supposed to have a femoral neck about yay big, and I don't have one. So now what do I have? I also have concern for a potential femoral neck fracture as well, right? I can see the proximal femur fracture. What other things could be going on based off of using my stepwise process and my technique that I need to make sure I evaluate for that I'm concerned about? So in clinic, I would be worried about a possible femoral neck fracture there as well. Yes, sir.
Is the Shenton line, is that pretty good diagnosing femoral neck fracture? Is that
I don't know if it's reliable. I've never used it. I've never seen it in a radiological report, right? So, and I haven't, I'll be honest, I haven't like looked into like any kind of studies of like, can we use this as a pathogenomic like type thing? So I would go with, I wouldn't hang your hat on it, but I might have to do more research on that because it's the first time someone's asked me that one. But I've never seen it. I've never seen a radiologist ever use that as like a determining factor of this is a fracture or this is normal. So I would lean towards no, it's not diagnostic. Good. Now, here's your femoral neck fracture, right? So again, I go through my stepwise process. I start with my normal on the side. I know what it should look like. It's a little bit different than most people in most people, but it's fairly similar, and we should have some kind of femoral neck, right? We have the head, we have the neck, we have the trochanter, the greater and the lesser. Here, I'm really missing the neck, and then the difference on this one is when I go through my cortex in my stepwise process, I can notice the gap here where the yellow arrow is, right? There's a break in that cortex. And if I follow my femoral head around, right here too. Right, look how smooth this is on the normal. How smooth of a transition I have from the head to the neck. Here I got head, and I got this triangular kind of point sitting there. So there's your neck fracture. Your signs are the break in the cortex on the superior portion, the non-smooth transition and triangular area on the inferior portion, and the fact that I don't have the size of femoral neck that I should. Almost all femoral neck fractures are surgical in nature. They're good and need to be fixed. This is not stable, right? The patient is not going to be able to just let this heal and walk around on it. They need to have surgery. Ortho will cover that more next semester, but femoral neck fractures are common in just surgery. Okay, SCFE, slipped capital femoral epiphysis. So, slipped capital femoral epiphysis. So if I have epiphysis, it's in what kind of patients? Peds, which means technically SCFE is what type of fracture? Well, yes, it's a pediatric fracture. A Salter-Harris fracture. What type of Salter-Harris fracture do you think it is? One. It's right in the name, slipped. This is a Salter-Harris 1. This will be the only Salter-Harris 1 I want you to make sure you know. This is super important. X-ray is your initial study. MRI is the study of choice to confirm the diagnosis for SCFE. Okay? But really, your meat and potatoes of SCFE and being concerned about it is all in your patient demographics. Okay? So how does it happen? It's a posterior inferior slippage of the proximal femoral epiphysis on the femoral neck metaphysis. Holy cow, right? It's around the hip joint, okay? It's in kids around the hip joint. Usually between 8 and 15 years old for females, 10 and 17 for males, just think teenager. And what this is these are the kids who are not fit, not active in the beginning, right? The fluffy couch potato kid is the video gamer. Right? The kid that, sits around all day and is watching TV, playing video games, eating chips, whatever. And then what happens is they get into high school a lot of times, or sometimes middle school, which is doing the females, like 8 to 10, right? Middle school and high school, and now social status matters, right? And they want to start doing stuff. Either parents make them get involved in organized sports, because that's the time to start doing that to see if they like it, or they take it upon themselves, I want to start doing activity. I want to start doing things. My friends are doing this, social status matters, I start getting into it. And they start doing stuff too fast, too quickly, and they haven't been doing things for years, and they end up causing the SCFE, okay? What's typical with this is it gets misdiagnosed as adductor strain. Like, oh, you're new to activity, you went too hard too fast. It's just an adductor strain. You're gonna be fine, take it easy, go slow, you're gonna be okay. So it can easily get missed, okay? Very commonly gets missed because of that. So if you have this patient presentation, get the x-ray. A lot of times we're like, hey, it's probably muscular. Go ahead, you're fine, right? Go to PT, rest, you're gonna be fine. That's how we talk in adults a lot of the times. You know, a lot of times with peds we do that too. But if you have this demographic, and it comes down to asking the right questions, right? Getting the good history, getting the review of systems. Hey, oh cool, so you started football, or you started track. Prior to this, were you into that, or did you just start this year? No, you just started this year, went to training camp, you know, and started to get some things. Okay, what were their hobbies beforehand? Oh, not a whole lot. They sat around, they didn't do much. No siblings, so they didn't play outside, right? Or there's no kids on our block, so they just kind of were, you know, doing their own thing, and then we got into this. Get the x-ray, okay? Don't just brush it off as an adductor strain or a muscle strain, okay? Key thing with this too is what typically happens if it is high impact activity, or let's say it's not skiffy, right? Let's say it is truly just overuse, right? Getting used to stuff, my body hurts, I'm sore. Which hips are probably going to hurt in those patients? 1, 2, 3 hips? Right? Yeah, 3 hips is the whole one, right? Both, right? This is going to be bilateral in your non-skiffy patients. Both hips hurt because I'm working the muscles, right? So if it's going to be a muscular thing, an activity thing, the odds are both hips are going to be sore. The legs are going to be sore, right? Like everything's going to kind of hurt, but in particular they're complaining about the hips. This, 90% of the time is one hip, just the right or just the left. Why? I don't have an answer for you why it doesn't happen bilaterally. Maybe they're more dominant on one side than the other, I don't know. But 90% of the time, this is one hip, not both. So that's another kind of sign for you in clinic. Going, well, why is it just your right hip? That's weird. Let's get an x-ray on it just to kind of make sure. Okay? Sometimes the pain can refer to the knee, but as you all know, hip pain in general can go to the knee a lot, even if it's muscular. So that's not really a telltale sign. It's that couch potato kid, adolescent years, usually starting to do more activity than they meant to, and they're having one-sided hip pain. Those are your concerns. Because this is an orthopedic urgency. Not an emergency, but it's an urgency. You should be calling ortho and letting them know, hey, when can you get this kid in? I'm concerned for a skiffy. Maybe a week or 2 or whatever it is, but it's definitely something that they need to know about. Here's the MRI. MRI is a study of choice on this, right? Here's the MRI and kind of shows you that gap in that physes of that femoral head compared to the normal. You see the thin line for the normal, and then you see the thicker gap line there for the skiffy. We already covered that. It's classified as Salter-Harris 1. And we talked about on x-ray how Salter-Harris 1s can be concerning. So again, clinic-wise, you get the x-ray, it looks normal, cool. Give it a week or 2, tell them to rest off, give them a note to say, hey, no practice for a week, let's try to rest. This isn't getting better with a week of rest, right? They're still going to be in pain when they try to go back to activity with a true week of rest, right? No practice, no running, no nothing, like just go back to your video game life for a week and let's see if it gets better. It won't, and if they come back in and they're still having pain, MRI is just going to be a choice to evaluate for the skiffy. Yes, sir? So it is usually one-sided. Probably not, and here's why I say no. If you're at the stage where you're ordering an MRI, right, you're not going to dictate that yourself. The radiologist will. They'll see this, they'll call it skiffy, and you'll go straight to ortho. Fair. What type of modality is this? MRI. How many things have I said you're going to have to interpret MRIs on the exam? Tracking? Because MRIs is not going to be in your wheelhouse most of the time. So I appreciate where you're going with that, right? But I wouldn't expect you to just pull this out just from the image. Showing you what the difference is, showing you why an MRI is important, why it will stand out. Questions on Skippy? Know your patient population so you know what to order, when to order it, so you don't miss it, right? Stress fractures, primarily in the femoral neck. X-ray still your initial study of choice. Why? They're coming in with hip pain. So what do we got to make sure? That there's not a bony abnormality. As we talked about before, when we talk about stress fractures, how often do we see them on X-ray? Very rarely, right? What's the typical treatment plan? Rest. Okay? MRI is still your study of choice because that makes the hip fracture stand out. Again, yes, CT might find them. Yes, bone scan might find them. When we look at everything else, I can find them with an MRI that doesn't involve radiation. So although CT and bone scan can find stress fractures, it is not your study of choice for stress fractures. Study of choice is the MRI. Alright? Treat this the same as you treat the tibial stress fractures, right? You're going to do an x-ray, not any better, okay, the answer is rest, maybe it's a stress fracture, but if it's persistent and you need to confirm it for some reason, MRI is your study of choice. You see the extra signal, we'll call it highlighted signal, with the yellow arrow compared to the other side. Right? That's inflammation, probably a little bit of blood or fluid, right, for that stress fracture. That's what they look like on MRI. And that's your stress fracture. Now let's look at avascular necrosis of the hip. Again, same as the scaphoid. Same as we've seen this before. Same as the scaphoid. All the same rules apply. X-ray is the initial study. It's got a poor collateral blood supply. MRI is your study of choice if you're trying to figure out do they actually have avascular necrosis or a fracture that I'm missing. Okay? And you have that increased radio-opaqueness, that increase here because of the sclerotic changes of the bone due to the injury in the bone dying. It will sclerose first, and then the last image we saw before, when it was like flat, that's when it's pretty much has died and it flattened down from the weight of the pelvis. But this is your early sign because your devascularized bone becomes more sclerotic. Femoral head, scaphoid. We have not talked about avascular necrosis anywhere else. So if avascular necrosis is a choice, anywhere else, it's probably not the right answer. All right, test taking skills. Only two areas we're concerned about it. Femoral head and the scaphoid. So here is that next picture, so to speak, right? It's where we had the increased sclerosis and then we started to lose the integrity. You can see it starting to flatten down a little bit from the weight. Here's your normal. Nice. Rounded. Sure, a little bit more radio-opaque here, but that's because the acetabulum is right behind it. Right, so we have more bone sitting back there, so I can expect that. But look at, there's no bone sitting behind here. All right, and then on top of that, we're starting to flatten down. This is not a nice round femoral head. With the increased signal, radio-opaque. Here's what it looks like on MRI, one of the slices, right? So this one's a little bit different now. We have the bone is bright. Again, you don't have to worry about that. There's those two weighted things, so we compare one side to the other. But look at, that's all dead. That's all dead and dying femoral head there, compared to the other side. This is why MRI is a study of choice. Not only does it confirm that it's happening, it gives us the extent of how bad it is. So your surgeons know what they need to do or don't need to do. I'm guessing, I'm talking ortho, but probably going to have a total hip replacement here. I don't think they're saving this femoral head with how far gone that is. There's no structural integrity there. Remember this chart?
Yep.
Good chart. Questions on the hip. What did we cover? We covered how to find a fracture. We covered avascular necrosis. We covered Skippy. Skippy is a very particular type of patient population. Okay. Femur is a lot like the humerus. There is not much there. It's one giant long bone. Okay? There's your anatomy. What do you notice about this different from all the other x-rays? It takes 2 pictures to get the femur. The femur is too long to be on one. So whenever you order a femur x-ray, you're actually going to get 4 pictures, 2 for the frontal view, and 2 for the side or the lateral view, because it's just too big. Even if you angle it a little bit different, we can get the whole humerus on one, we cannot get the whole femur on one. So yes, some of this area here is also on this picture right here, right? So like this ballpark is probably the same as this. So if you see like a fracture here and a fracture here, likely not 2 fractures, probably the same fracture, right? If you see it here and kind of like here, probably the same fracture, because there is overlap, right? This person is not like, 10 feet tall. It's not why the femur is that long. You can't just put them together like this and make like a really long femur. But why do they do this? Because what do we say about an adequate x-ray? If I'm going to look at a bone, I need the joint above and below, correct, right? So only way to get that and get the full joint above and below is to do 2 different pictures. Why do I have a left marker here? Well, because this one I could tell you is a left, but if I had just this image, I have no idea if that's left or right. I don't have the pelvis there to confirm it. Some people will say, well, I can tell by the soft tissue. Sure, maybe, but I'm not going to guess, right? If it's not for sure, I have the pelvis and I know, I want the marker to tell me it's left or right. There's your femur bone. Here's what the lateral looks like. Boy, that proximal lateral looks just like the frog leg, right? Because it is. It's the same thing, right? And then here's the lower part. So again, there's overlap on these x-rays. All right. Pediatric. Oh look, it's all in one film. They're smaller. We can do that. And then your pediatric lateral. There's really nothing abnormality-wise on the femur I can teach you that I didn't already teach you on the humerus. Describe the fracture. That's it. Know what the femur looks like. Know the anatomy. So if you see a fracture, you can describe it. There's nothing special disorder-wise that's specifically for the shaft of the femur. What kind of fracture is this? Pathologic. Remember, once it goes through a bony lesion, there's some pathology there, we just call it a pathologic femur. We no longer mess with the fact that it's an incomplete oblique fracture, right? Why? Because that's less important. It's more important for someone to know that there's something else going on in the bone here that likely caused the fracture, probably due to structural integrity, probably due to weakening or something along those lines. That's more concerning. I have pathology that caused a fracture, pathologic fracture. Good. Yeah, really good. You're ready for this. There's chocolates, I like it. Knee. Knee's got a lot of stuff going on in it. Knee's got a lot of special tests, a lot of physical exam things that you guys are learning and doing mostly right. But you'll get more practice with it, so I have so much of it. Here's what the x-ray looks like. Now we talk about the arthritis stuff, just paying attention, looking at that joint space. You should have that nice joint space, right? Okay? Knowing your condyles, knowing that there's cover or overlap of the head of the fibula and the tibia. So when you're doing your tracing, right, you should see some shadow and some overlap right here. That's normal. It kind of hides back there. If you think there's a fracture in the tibia, you're like, oh, is that a fracture? Oh. Follow the bone of the fibula. If it goes along the lines of the shape of the fibula, it's not a fracture. It's just the bone overlying it. Okay? That's the patella. That is not a bone lesion. That is not a fracture. Don't get that confused with a fracture. I think oftentimes when we're learning this stuff, we see the knee, we completely forget that the patella is supposed to be there. This thing jumps out as the shiny toy, and then we kind of focus in on it. And you guys are in the stress of the exam and not wanting to miss stuff, and so you're like, oh, there's something wrong there. That's just your patella. That's supposed to be there. And it doesn't always have to be perfect like that, right? It could be slightly shifted to side, potentially. Doesn't mean that there's a major, maybe there's abnormality, but not from a radiological standpoint, right? And maybe more of an ortho standpoint, depending what's going on. But it could be a little bit lower. Sometimes the tip of the patella right? Depending on the patient and how their anatomy is, might be sitting right down here, and it's a little bit below into the joint area. It's okay. If you trace it out and it's the shape of a patella, that's a normal finding, okay? Here's your lateral. Now, when done appropriately, your two condyles should line up very nicely with one another. See how they're kind of symmetric in there? A little bit of gap between the two, right? But as far as on the bottom here, they're pretty symmetric. When done appropriately, I'll let you know a little secret. When they do lateral knee x-rays, typically they take the tube and they angle it about 5 to 10 degrees up towards here to try to make it look like this. Because you remember magnification, right? The top condyle is higher away from the film than the other one, so it's going to magnify a little bit. So it will project kind of bigger, and sometimes when they don't do that, you'll have one condyle here and one will really loop down kind of down here, and it looks like two different, like, wow, one's bigger than the other. Well, so it's because they didn't move their tube to try to superimpose them for you. And that's what we're seeing here. We're seeing just a little bit of that magnification, okay, from that condyle that's further away from the film. Can't tell which is which, okay, but they should kind of line pretty close to one another. Got your patella again. Again, don't forget about your overlap of your tibia and fibula here. Make sure that's tibia or fibula, right? There's no fracture there. That's just a fibula shadow. So follow that around. What's this guy right here? It's not labeled. Talked about it. It's the start of one. Remember the sesamoid bones? Right? So sesamoid bones behind the areas of high friction, high movement. Most commonly, thumb, toes, right? Your fingers and thumbs, toes, behind the knee. Behind the knee. So very common for you to have sesamoid bones back here. How would I determine if it's a sesamoid bone or a fracture? Well, what are they coming in for? Right? Are they having posterior knee pain? Right? If not, and I'm getting this because like, oh, it hurts like down here where my tibial tuberosity is, probably not a fracture, probably a sesamoid bone. How can I verify that? Get the other side. They have one on one side, they probably have it on the other. If I'm coming in with just right knee pain, you can see it, then my left knee should look pristine. Right? So if I have this on my left knee as well, probably not a fracture abnormality like the sesamoid bone. Sunrise view. This is really nice to take a look at your joint spacing between your patella and your femoral condyles. You should have this beautiful little sunrise view. Here's how they shoot it. Right? They're shooting the x-rays right through that joint space, which is why it opens up like that. In your patient with significant arthritis, you won't really see one, or it'll be like super tiny. It'll almost look like the size of like the pediatric, like some of those pediatric physes are like super small. That's how small it'll look when they're arthritis. But you'll also see a bunch of increased radiopaque along the edges here, along the cortex, because it'll be inflamed and doing arthritic. And that's your sunrise view. See? Here's one right here. See how the patella comes down into the joint space? Why do you think that is? What kind of patient is this? Pediatric. Good. You see the physes right here? Right? They haven't fully grown up yet, so by the time they're an adult, I'm sure this will project up here like the other one that we saw. But how do I know if that's an abnormality or not? Well, I'm going to trace it all the way around and see if I see something in the vague shape of a patella. If I do, then it's just the patella. We're moving on. Here's your pediatric lateral. Your condyle is going to be way more superimposed on this one because, again, they haven't grown yet, so they're not that large yet, so they don't magnify nearly as much. This is not testing on the MRI stuff, but ACL, PCL, so it's kind of, I like this one because it kind of shows you how you can actually see these tendons in the MRI and whether or not they're connected or not. The Q is quadriceps tendon, the P is patellar tendon. For those of you that want to fully label it, just so you can kind of look at it and see. And so because I can see that, and I know the colors, and I'm like, okay, so tendons on this particular MRI are dark, There's my ACL, there's my PCL. Is the PCL torn? No, I just don't have that slice. I'm gonna scroll a little bit more, right? But not touching on MRI stuff, but just want you to have it. So here's a good example of a normal ACL versus a torn ACL. See that pretty ACL right there going from the bottom to the top, and it's not there. That's normal. There's nothing connecting if it's been torn. So, all right. Menisci, okay? What I want you to focus on this slide on is not necessarily finding the abnormality on the menisci or on the MRI, but your symptoms. Popping, clicking, the biggest thing is buckling and locking of the knee. Pain with that. You guys are learning the McMurray's test. You're learning the, I think the Apley's and the Thessaly test, right? I know the Thessaly's not in the grade sheet, but you're learning, it's still on your slides, I saw that. That's all you really need to diagnose a meniscal tear. The MRI is then for where's the tear, so they know whether or not they're going to do surgery, because they don't surgerize on all of them. It's an official word, surgerize, for those who don't do it. So, symptoms is going to be your concern for meniscal tears. You're still going to order an x-ray first, because what if it's not a meniscal tear? You don't have the bony imaging to look at it, right? X-ray is going to be your initial study for all of your MSK stuff. Sometimes it's also a study of choice, and a lot of it, right? Sometimes it's not. But it's always going to be your initial study.
Do a sunrise with a meniscal tear?
You can. So it's a standard knee. You usually get AP, lateral, and usually the sunrise is standard for most procedures at most places. But yeah, I mean, because they can still do this with a meniscal tear. It just hurts primarily with more like the pivoting and the turning or doing stairs or whatever. But bending is usually okay. It just may kind of catch or pop it.
The joint spacing you can reach with meniscal tear?
Probably not, because it's just the meniscus, right? So it's not, remember the sunrise is looking at the joint spacing between the patella and the femoral condyles. It has nothing to do with the menisci, which are on the tibial plateaus, right? So completely different anatomical areas. So meniscal tears should not cause a change in that sunrise view. Patellar fracture, okay? What's really crazy is these things can get nuts, right? This patient was lucky in the aspect to where, yeah, it's a complete fracture, but I'm guessing there's still some kind of piece of bone or something holding it together, because the quadriceps tendon and the patellar tendon didn't pull it apart, right? You gotta remember, it has force on both of these tendons that kind of hold it in place. So when it completely goes, a lot of times it'll pull more apart. My mother-in-law about 2 years ago was walking the dog and she fell on it. I mean, she shattered this into like 7 pieces. So they had to go and do surgery and like almost make like a wire cage to like put it all back together again. And she'll have that in her for the rest of her life, and she can't fully bend anymore. So a lot of times this will happen either in your, we're just gonna say a lot of times elderly patients, primarily because it takes a fall directly onto your patella. Not often for us to fall that way. If we're gonna fall, we're gonna catch ourselves and fall some other way. Usually you trip over something, fall on your patella. If you're osteoporotic, you're at more risk of doing this, but it's gonna be a direct impact on the patella that's gonna cause this kind of fracture. All right, and on that note, go ahead and take a 10-minute break and come back at the top of the hour. Good questions on the break, really good questions. So please bring that energy when we do the review of like the questions, right? I promise you, if you're sitting there in your head right now and you're like, God, I don't want to ask that. That's going to sound like a stupid question. I don't want to do that. I promise you, at least 5 or 6 other people in this class have the same question that aren't asking it. So please ask that question. So the 2 ones that I got asked in this one are really, really good ones. They're all really good, but 2 that I want to kind of hit on. This in particular. This is not an avulsion fracture. This is not an avulsion fracture, and here's why, right? People are like, oh, I got the quadriceps tendon and the patellar tendon. True, so I can see why you would think that. But remember the mechanism of injury in a avulsion fracture. It's a tendon or a ligament that attaches to a bone and rips a piece off, right? Attaches to a bone. Think about the anatomy of the patella, right? Really, the only thing separating the quadriceps tendon from the patellar tendon is the patella. It's all kind of the same tendon guy, right? So really that patella is kind of enveloped or encapsulated within that tendon. So this is not an attachment. The patella sits in there, but the quadriceps tendon and the patella tendon don't attach to a portion of the patella, so it can't really rip off. Where you have a potential for rip off is down here at the tibial tuberosity, where that patellar tendon comes in. That can end up being an avulsion fracture, because all that does is attach to the surface of the bone. Nothing's just attaching to the surface of the patella, right? It's kind of encapsulated. So that's why you don't have avulsion fractures of the patella in most cases. Does that help understand that a little bit? Right? Because you see tendon and bone, you're thinking avulsion. Second one, remember in general, right? I recognize the fact that you guys are looking at these images and you're sitting there and you're going, okay, this looks the same as two other things that we looked at. How the heck can I tell the difference between this based on the image? If you're asking yourself that, it's possible that you can't, okay? And that's going to become important in block 2. Block 2, a lot of stuff with the chest and the abdomen. A lot of stuff looks the same. And you're like, okay, well, I know that's abnormal. And that could be one of 4 things he talked about. Which one is it? An example in this block would be your pyogenic, non-pyogenic infectious arthritis. How the heck do you tell the difference in that with just the x-ray? You can't. That's where the timing, the patient's symptoms, you know, the mechanism, all of that comes into play. Very rarely in clinic are you just going to get a picture and say, diagnose this. Now, in this course you will, because that's what this course is. But in block 1, you can diagnose a patellar fracture with just an x-ray, right? I don't need a patient population, a mechanism of injury to diagnose that. But in some stuff I do. We just talked about Skippy, right? I need to paint that picture for you because in clinic that's what you're going to get painted. So like this is like this semester, some of these courses, right, where you bring it all together. It's like this one piece of information might not be enough, but if I associate it with the vignette, the history, the patient presentation, now what's my most likely diagnosis? And that's what medicine is. So if you're doing that through this block, by all means, if I'm asking you to clarify that you're on the right track and how to kind of sort through that stuff, happy to tell you like, hey, yeah, no, you need more than just a picture, right? Because in block 2, the big scary block 2 that everybody has heard about and freaks out about, right? That is part of the challenging part about block 2, is understanding and recognizing that it's not just the picture. You have to understand the whole patient concept to come up with a most likely diagnosis or abnormality. Okay? You get a taste of it here with some of those things, but we'll hit it even more next time. Does that make sense? All right, so you're starting to transition into that whole patient concept. Every piece of information is valuable, and some pieces are not valuable, right? They're meant to be distractors. Like if I were to tell you, you know, this abnormality and give you, trying to think what would be a distractor on something like this. This one's pretty straightforward. But I might give you an age of a patient that's a 68-year-old female, but the condition has nothing to do with osteoporosis, right? It's like a radial head fracture, right? Which we didn't really associate that with osteoporosis anyway, but so that would be a piece of information that I've given you that's really not useful in that case, but you gotta, you know, pull that out and be like, I don't need that for this one, because osteoporosis isn't a choice, right? Or it's not the areas that we talked about, like the compression fractures of the spine, or DEXA scan, if you want to do study of choice, that kind of thing, okay? All right. Remember that bipartite patella we talked about for normal variance? That looks like a fracture. What are 2 ways I can know that that's not a fracture? Bilateral x-rays, I heard it. If it's the same on this other side, if it's like this on this side, it's probably going to be the same on the other side. And history. Did I fall on my patella? Do I have pain? Like, this is really easy. Just like, does that hurt? They're like, no. Did that ever hurt? No. Did you ever break your patella? No. Normal variant, right? So this is an example of definite patellar fracture. Looks like a patellar fracture, but if I have no pain in the area, if I have no mechanism of injury, I didn't even fall and I'm coming in saying my knee hurt because I've been running a lot, that is not going to happen just from running. You need to direct it back. Right? So use all of your tools. If you're concerned, is it a normal variant? Then great. I'll get the other knee just to confirm that. Yes, sir.
What's the likelihood that a patient comes in without some sort of knee complaint, then you do an X-ray and you see this?
Valid, right? I'm not saying they won't come in with a knee complaint. They're going to come in with a knee complaint. That's why you're going to order this. But unless they're point tender, think about what you would need to do. Unless they're point tender on that area of the patella, this is not the reason for their knee pain. Right? A patellar fracture. A fracture, if you push on a fracture, it is extremely painful. For those who have never had one done, it is extremely painful. So if I push here and you're not having pain, that's fine. Right? And then if I want to be extra safe, I'm going to make sure, I'm going to order the other knee. And I'm probably going to see the exact same thing. Okay? If I'm coming in for achy knees because they're stiff or when I run they hurt, right? Those are the kind of knee complaints you're going to get. Maybe you order an X-ray just to kind of make sure and you find this. Just don't automatically be like fractured patella, right? Especially if you don't have the history and the symptoms that make you think the patella could be fractured, especially with a bone that's so close to the surface, right? It's kind of like that scaphoid. If you have a scaphoid fracture, it hurts to push on it. That's why we do that on the physical exam. When they come in for that follow-up, you're going to do it again. How do you feel safe when it's not a scaphoid? They come in and you're like, no pain, and you're pushing on, no, great. I'm not really concerned, right? Because it hurts. Good question. What is wrong with this patient on your right? Osteoarthritis. What type? Oh, there is one factor with this X-ray that you can have it most likely.
Bilateral.
Bilateral tells you what? Probably primary. Remember, secondary osteoarthritis is unilateral the majority of the time, right? So, do primary and secondary osteoarthritis look the same? Yes, they do. Primary versus secondary, bilateral versus unilateral. There's just one example. The other one was age. So for those of you who said it depends, I need more info because you wanted the age of the patient, whether or not there was trauma, you're absolutely right. That will also help you distinguish between those two. I like this one because look at the joint space of how it should be, and then look at what it doesn't have. Normal, primary osteoarthritis. How painful do you think this is? It can be very painful. You'd be surprised. You might have some asymptomatic patients like this. And we're like, oh, I have pain tolerance. You should have said something years ago, right? But you see here, I want you to focus on not necessarily the abnormality in the joint spaces. I want you to look at more particularly the right patella, right? Remember how I told you sometimes they can be shifted off to the side a little bit? And there's your eye, and that's what I was going to get at. So now my next thing is like, is that normal, is that not normal? So I go through my system, look at the gap I have between the tib fib here, and look at the spacing I don't have on the tib fib on the other leg. That tells me the way their legs are rotated is not the same, which is going to account for the projection of that patella. Context clues, right? So I am not worried about a shift or an abnormality with where the patella is at, because when I compare it to the other side, and I look down here, it definitely shows that a portion of the leg is for some reason, maybe it feels more comfortable for them, right? The tib fib positioning doesn't 100% matter when you're doing a knee x-ray because we're more concerned about the tibia. So if it's rotated here with the spacing, it's not a bad abnormality, like it's not a bad read, it's still a good film. Does that make sense? Because I'm not evaluating the tib fib as a whole, I'm evaluating the knees, but that's what causes that projection there. Okay. That's it for the knee. Okay? The leg, or in this case, the tib fib. There's your anatomy. There are two long bones. They come together. We talked about it already a couple of times. I'll just hit it real quick one more time. Watch out for the overlap of your tibia and your fibula, both superiorly and inferiorly. Do not mistake the overlap for fractures. Same thing with the fibula and the talus. Right down in here. Right? There is some natural overlap there on this frontal view. Same thing with the lateral view. Superiorly overlap, inferiorly overlap. Here over. You can see here, if I look at my medullary canal, maybe just in front of that fibula, it looks like there can be a dark radiolucent line right there. But when I follow my fibula down, it's just follow the fibula. Right? This is just overlap. There's no break in the cortex. There's no break in the cortex of my tibia here. This is just overlap. Okay? There's your pediatric one. And there's your pediatric lateral. Here's an example of a question you can see. You won't see this question. Not like that. That would be unfair. 24-year-old male presents to the emergency room, status post-injury playing football. He took a direct blow from a diving tackler's helmet. An x-ray is ordered to further evaluate what best describes the image seen. Do it with yourself. Take about 30 seconds. Big yellow arrow probably helps you find it, but I was hoping you would ignore that. So I have the transverse fibular fracture. And what kind of fracture do I have on the tibia? How many say spiral? How many say not spiral, just transverse? How many just don't want to answer? It's almost right. So what is a spiral fracture? It's a type of rotational force, also a type of oblique fracture, right? With just this image, I don't know. I can't see posteriorly. So if I were to give you this, I have it labeled as transverse. I will accept those of you who are like, hey, I think it's spiral if, and you answer this to yourself, if you said the reason you think it might be spiral is looking at the depth of the bone layers right there in the inferior portion of the tibia. If that's what made you think spiral, I'm okay with you thinking that because that's what I taught you, right? So on an exam, I would have either transverse in the tibia or spiral in this case because it's not a clear-cut line on one versus the other. I didn't give you a rotational force. This isn't an oblique fracture from what I can see with the way that I told you a spiral is a subset of oblique typically, right? So because of what I taught you, I would only give you one or the other. I want another image if I'm going to determine if this is truly a spiral or not. I would want the lateral image to go with it. And in clinic, you're going to get that, right? So that's really what I want you thinking. I want you going, oh man, that could be a spiral. Not sure, but if I was in clinic, I would want to look at the other image to confirm that, right? That's kind of where I want your brains in that aspect. Yes? Right there? Yeah. Take a peek at it on my screen. I don't think it is. Yeah, that is a fracture of the fibular head. So for those that were looking at it, right here in the bottom of the cortex, there is a small break in that cortex that goes up. That is a fracture of the fibular head. Good. Questions on this one, right? So maybe spiral, maybe not, just because I need that second image. But what I love is the fact that there was a large group of you here who looked at that layering and said, I think it's a spiral. So the next step I want your brains to go is go, what do I need to do to confirm? If I was in clinic, what else would I need to look at, right? On a test, you just got to answer the test with the answers that you have and the best that you can. But in clinic, which is what I care about, because that's what I'm teaching you guys to do, that's how I want your brain. All right. Now, I am not going to test you on the Mason-Noué fracture. It's French. I'm not French. All right. Mason-Noué fracture. But this is extremely important that you need to know. When you, and we're looking at the x-ray, when you get a lower or an upper, either way, right? Let's say you order a knee x-ray and you just get this fracture because you saw how sometimes the knee comes to the tib. Or let's say you order an ankle x-ray and you just get this joint widening down here in the mortise joint. And we're going to see when we get to the ankle what a normal mortise joint looks like, so it'll stand out a little bit more to you. Kind of like the calcaneal fracture, do not stop, right? If you get a whole tib fib, you'll see everything, right? Not a big deal. Where we run into a slippery slope is when we just order an ankle x-ray because they have ankle pain, and we see the abnormality and we go, okay, cool, I don't see anything else on the ankle, it's good to go. No, you need to get up here. And same thing, we order a knee x-ray and we see a small fracture in the fibula, and we're like, okay, well, we fixed that, okay, it looks like it's non-displaced, well, you're good to go. You need to get down here, because what happens here is you can get a fracture of the medial malleolus or a rupture of your deltoid ligament of the ankle, along with the fibular fracture, and this becomes an extremely unstable lower leg, right? It's called a Mason-Yeo fracture. It's when you have both of them. And if you miss this, it can cause significant harm to the patient. You'll hit this more in ortho because this is a call ortho yesterday kind of thing, and keep them non-weight bearing until ortho can see them. Okay. That's it for the tib fib. Describe the fractures just like we did for the forearm for the most part, right? And the femur and the humerus, and now we'll go into the ankle joint. There's all your anatomy. Yay. Okay, so we have our AP ankle. Note the same overlap we talked about on the tib fib, it's still there. All right, understand your anatomy because here's that mortise joint. So that's the picture we just saw before that was abnormal. Here's the normal mortise joint. Mortise, mortise, and some people say it differently. But what this is basically an oblique. They take the ankle, they rotate it about 15 degrees, and the idea is to open up this joint right here to make sure everything is aligned and the spacing is the way it's supposed to. So now take a good look at this one on the screens. All right, look at the size of that. Look at the red circle and the size there. Right? So that's what you're watching for, is the widening of that joint space. Nice little plateau. Here's your lateral. Great view of the calcaneus, one of the best views of the calcaneus you're going to have. You got your joint spacing there, nice little talar dome. Fibula and tibia come right on in. You still got this overlap, right? This is normal overlap for the tib fib on this side. Do not mistake that for fracture lines. You start to see the navicular of the tarsals a little bit. Okay, the cuboid is really well here. Start to see some of that joint spacing. These are not fracture lines. These are the joints of your tarsals, just like how we have some of the joints of the carpals when we do some of the wrist x-rays. Okay. Pediatrics. Not going to ask you to find a fracture within here on pediatrics unless I'm asking you to name Salter Harris's. Yeah, see, that is not a transverse fracture of the fibula. That is not, right? And that's why that gets confusing. That's why I'm not going to do that. Normal pediatric lateral, right? This is not a fracture of the calcaneus. This is a growth plate that hasn't fused yet. You can see how confusing that would be. Not fair to you guys. Here's what a normal CT looks like. Again, look at the graininess, look at the boniness. That's normal. It's called the sinus tarsi. It's just a little tunnel that comes right where the talus and the calcaneus kind of come together. Okay. Much like the pelvis, we talk about the Mason-Yeo one, right? If I have fractures or gaps in both bones, that's unstable. They should not be walking on this. But if I see this, now here's my question. If I see this, do I need to get the upper one? I will. I need to. I already have the information I have. I need it. Remember, I was trying to figure out if it's stable or unstable. So if I see this joint gap, I need to know if the fibula is fractured to figure out if it's stable or unstable. Well, I got my fibular fracture right here, so I already know this. I'm probably going to get it because ortho's going to want to know if it's fractured superiorly as well. But I have my answer right here. I have the deltoid ligament rupture and a fracture in the fibula. I have an unstable ankle / tib fit. The reason we get the superior one is when the fibula looks like this, and the fibula doesn't look fractured, and I have the joint gap here. I need to make sure that fibula goes all the way up, but that fracture's not somewhere else. Oh, look. The only thing that's like a fracture that's not a fracture. Osteochondral defects, okay? So every once in a while you can kind of get this little defect in the talar dome. It's not concerning unless they're having pain in that area. The difference between this and a fracture, it's well corticated, right? So it's got a cortex all the way around it. So maybe it gets mistaken for an old fracture that never healed, like a non-union or something like that. That becomes a patient question in clinic, like, hey, did you ever have a fracture to your ankle? No. Okay. All right. Biggest thing with this is we care about this if when. Pain. Is it causing pain? Is this why they came in? Are they having issues bearing weight? Now I care more about it, right? And that's the difference with unstable versus stable. Stable, if it's kind of sitting in there, I'm not really worried about it if it's not causing pain. So let's say I got an ankle x-ray, it's a CT, but you might be able to see on an x-ray, because they were having pain like over here, right, on the malleolus, or they were having calcaneal pain, or something like that. So that's why I got the imaging. And I find this osteochondral defect. Well, am I having issues with it? Am I having pain with it? How long has it been there? I don't know, but that's not why they're here today. So we'll focus on why they're here today and see if they're still having issues. Ortho will go into more detail on whether or not and when to do something about this, but look below the yellow line. This is a bad day. I tried to look up the mechanism of injury for this patient. I couldn't find it. This is the only talus fracture I've ever seen. Doesn't mean it can't happen. I'm not ortho, right? I'm sure ortho has seen a lot more. This is microcalcaneus. This is hard to do, right? This guy's going to need surgery likely. Make sure it doesn't come apart because it's almost. Is it complete? Is it incomplete? We're going to probably call it complete because it sure looks comminuted to me back here. Right, I got piece, little floaty pieces kind of within the fracture. So, only a complete comminuted talus fracture. But really the biggest thing for the ankle with what we were talking about is that Mason-Yeo thing. I mean, I'm not going to give you that test, but I need you to know that. But really just being able to know what normal is, primarily with the oblique and the other images, so that if there's a fracture in it, you can describe it. There's no special names for anything, except for Mason-Yeo, but that's for a future course. Other than that, it's just finding the fractures and knowing the anatomy. Questions on the ankle? Now the foot, much like the hand, does have certain things that we want to call in and out. Prior to getting into the foot, if I am getting a hip or a knee x-ray and I know I might send the patient to ortho, what type of x-ray do I want? Functional x-rays. Talked about it briefly a couple of classes ago. Weight bearing, right? Weight bearing x-rays. You get a true look at that joint. Especially when we evaluate for like the arthritis, I want them weight bearing. I want to see what that joint looks like. Don't order regular ones because they're just going to have to get them again if you send them to ortho, because ortho will not work without weight-bearing x-rays. They won't do it. They'll make the patient go get more. They like their things a particular way. I love Newton Douglas. You'll see. He'll tell you all about it. All right. So, foot anatomy. Sorry, I'm a little too quick there. Much like the carpals, notice how some of the tarsals kind of overlap with one another. Right? Primarily looking at my cuneiforms with the cuboid. There's some overlap with the navicular here, right? They all kind of overlap over one another. So know what your normal looks like. That's why we get a dorsal plantar view. We'll get an oblique. Look how it opens up those joint spaces with the foot, much like with the wrist. We did that oblique, kind of popped open those carpals. Now we can get a wonderful picture of all of the tarsals and their joint spaces. Not so much my medial and intermediate cuneiforms. Those are kind of all over each other now. But if I go back to here, here's my medial, so I can see that really well. Intermediate's in, right? But I can see the intermediate right here now. See the intermediate right here now. The medial one's hidden, but the medial one I have right here on my AP, or my dorsal plantar view. But this one primarily designed to look at all those joint spaces within the carpals. Where do people get hung up on this one? That's overlap. That is not a fracture of the second metacarpal, right? That is not a fracture of the second metacarpal. That is overlap from the first one. Follow your bone all the way through. Okay. Here's my lateral. That was nice this time and labeled sesamoid bones for you. Right, down here sesamoid bones. May or may not be there. But again, the design for the lateral, right? I can't see a whole lot of my metacarpals here. Right? They're all superimposed on one another. I don't know which one's broken or what's going on, but what a great picture to go ahead and look for any type of dislocations, right? Within the tarsal bones, within the metatarsals, any of that kind of stuff. We can see those dislocations. The patient is doing this weird thing where like they got their toes up and like one toe down. I don't know what they're doing. That'll happen sometimes. Much like the fingers too, they'll get a lateral, maybe it was a big toe issue, a first toe issue, so like they had the patient do that, so you can put this separate from all the other ones and take a look at it. That's possible. What do you do for a broken toe? Buddy tape it. There's really not a whole lot we're going to do for broken toes. Stop kicking the chest. What's that? Digital lock. Digital lock, that'll be good. Knock my toe, let me up. Then they kick something else and break even more, they won't even feel it, right? It's a win-win. Don't do that. Alright. Normal CT, right? There's that sinus tarsi. MRI. I think at this point, seen a lot of these. Know which one's which. Alright. What's the abnormality? Okay, so maybe an Achilles tendon rupture, avulsion fracture, right? Because what does the Achilles tendon do? It just connects to the surface of that calcaneus. Rip it right off. Nice part about lateral ankle x-rays, I can see my Achilles tendon come down here. See that darker radiolucent kind of thick line right back here? Connecting right here? That's my Achilles tendon. It's such a thick tendon, it's one of the few we can actually kind of see it connect on x-ray because it's so thick. Right? So we don't notice that. We got some soft tissue muscle, we got some skin and some subcutaneous, and then there's my Achilles tendon. So soft tissue, Achilles tendon, right in there. So now, when I look at my avulsion, I can still see my Achilles tendon coming down. Kind of encapsulates right here. It looks like it might stop, so I would say this is probably a complete rupture. Because I can't really, maybe there's a couple of fibers still connecting down here to the calcaneus, maybe, but definitely enough to pull this right off of the calcaneus. Now the nice part about that is you will have, I don't know if you've learned yet, you learned the Thompson test? No? Okay. You'll learn that in ortho, yeah, the Thompson squeeze test, it's really cool. You can find out immediately if a patient tore their Achilles. All you do is flip them on their stomach, have them bend their knee up, squeeze their calf muscle. The foot flexes, because when you squeeze the calf muscle, you're pulling on the Achilles, and it forces the foot to dorsiflex. If the foot don't move, the Achilles ain't attached. It's that simple. And so like for this patient, I'd be like, is it complete or is it not? I would do the Thompson test. If it moves even just a little bit, it's not a complete tear. It still may need surgery, you need ortho to get involved, but it's not a complete tear, right? A lot of Achilles tendon ruptures are treated non-operatively, believe it or not, unless you're an elite athlete. In some career fields in the military, we are considered elite athletes, so they may do surgery on them. But in reality, the recovery time from surgery versus non-surgical is almost exactly the same. Almost exactly the same. The difference is how stable is a scarred Achilles tendon going to be versus one that was reattached. And that's why your elite athletes, all your professional athletes are definitely getting the surgery, whereas a lot of regular people or certain career fields in the military will probably just go non-operatively because the odds of re-tearing it are pretty slim unless you're doing something on a daily basis that causes a lot of tension and torque on that Achilles. You'll learn next semester a little bit about it. How do I know I tore the Achilles before the x-ray? Most common thing is, that was really weird. I was just standing around or I was playing soccer or whatever. Felt like somebody threw and hit a rock in the back of my heel. I looked and there was nobody there. Or I felt like somebody went and kicked me. I looked and there was nobody there. What happened afterwards? I was still able to walk around for a few steps and all of a sudden it started hurting and I kind of went down. Like, it's not like this massive pain a lot of times when it happens. It's more kind of like, what was that? Yeah. And then like, after a little while, then the pain kind of kicks in. So, all right.
Could that be a sesamoid bone in that area?
In here?
Yeah.
No. Yeah, good question, right? No. Sesamoids typically do not appear in the Achilles. Calcaneal fracture. What else are we imaging? Lumbar spine, because that energy has got to go somewhere. I will accept those, I understand those who want to do a knee or want to do a hip, but you have to, at a minimum, do the lumbar spine. Cannot forget to do that if you have a calcaneal injury. Excuse me. Because of the velocity that it takes. These morons. All right, or Tom Cruise filming a Mission Impossible movie, since he does all his own stunts. Harris view down here, that's going to be more for ortho. Okay, they will teach you about that Harris view for calcaneal fractures. Here's your most common patient presentation, people. Falling from a height of 6 feet or more, usually in your roofers, your tree trimmers is a big one around here. Jackie Chan, yeah. Yeah, more Tom Cruise, but yeah, Jackie Chan, he doesn't really jump from high things. Yeah, that's because he's old. Probably the same age he is now. So, biggest issue is if it is in the talar joint, like we saw before, that longitudinal talar area, it's going to cause significant issues for quite a while. So just don't miss the calcaneal fracture and don't forget to get a lumbar spine x-ray when you see it. Okay, getting down to the end, guys. Liz Franck. Okay, I think this one's French too. Some people say Liz Frank. Pretty sure it's Liz Franck. This is an injury of the toes in between typically the first and second metatarsal. Okay? So what it is the cuneiforms and the base of the second metatarsal have kind of separated out a little bit, and it's misdiagnosed most of the time. Why? Because people order feet x-rays non-weight bearing. The only way to see this is if you get a weight bearing x-ray. If you don't order it weight bearing, you will not find this. Typically, you're going to have your rotational force of the forefoot or plantar hyperflexion with axial loading. So what the heck is that? So plantar flexion and then axial loading, which is why MDCs are a big one, because people see a car accident coming and they kind of freak out and it puts them in a weird way and they get that impact while they're plantar flexed and it just disrupts the second metatarsal in the cuneiform area. X-rays your initial test, okay? If you get the x-rays and they're normal and you still have clinical suspicion, I will tell you what that looks like, get the MRI. MRI is your study of choice. This is surgical. This is surgical 100% of the time. Here is the difference. So the blue arrow is the abnormality, okay? Right in here. But what's key is the second picture. The foot on the left is normal. The foot on the right is abnormal. Look at the spacing primarily between the first and second metatarsals and the tarsal. Look at the gap. What happens is There's a disruption there. So if you're not weight bearing, there's no pressure to cause that to separate and bring that gap on. When you're weight bearing and you're normal, it stays the way it's supposed to. But the other side opens up. That's your Liz Franck injury. You're looking for this gap that's here in the blue. This is a significantly big one. But then here's also the subtlety of ordering both. If you suspect a Liz Franck injury, you're going to order both feet. Because I want to compare your affected foot to your unaffected foot. Okay? If it's normal, and there is ecchymosis on the plantar side of the foot, right in between the first and second metatarsals of the foot, order the MRI. There are very few things that cause bruising specifically in that area. This is one of them. So any foot injury I have, trauma injury, shoes and socks should be off in the exam anyways. I'm looking at the bottom of the foot, and I'm looking for any ecchymosis in that area to lead me towards Liz Franck injury. Because then if I get my x-ray, weight bearing, and it's normal, I'm ordering the MRI. A lot of times it won't be. You'll notice it with just this, and you don't need the MRI, and then you're immediately picking up the phone to ortho. Questions on Liz Franck? X-ray study of choice. Sorry, X-ray initial study, MRI study of choice. Right there, yellow and blue. X-ray initial study, MRI study of choice. Must be weight bearing. Will not see it if it's not weight bearing. All right. So now these are just some comparing and looking at some X-rays. On that AP and oblique X-ray and the lateral X-ray, over here, these three, this is where I would tell you there's a lot of different things going on, right? So if you were to describe this to somebody, completely appropriate for you to just say third, fourth, and fifth metatarsal fractures. Right? I don't need you to break down, be like, well, the transverse and the fourth one, and the third one is kind of oblique, and maybe one's coming. Listen, I got someone who fractured their third, fourth, and fifth metatarsals. Book closed, done, finished. Right? If I'm going to ask you to describe fractures, it's going to be one of them or two of them. Like if it's like a tin fib or something, it'll be very straightforward. It's not going to be like a paragraph answer of like 3 different lines or something like this and have all those. Okay. Okay. Jones fracture. Almost done. Much like we had the Bennett's and the Rolandos at the base of the first metacarpal, we have the Jones, which is at the base of the fifth metatarsal. Don't get it confused. Boxers was near the head of the fifth metacarpal. Bennett and Rolandos were at the base of the first metacarpal. Jones is the base of the fifth metatarsal. Letters and words matter. So, what ends up happening is significant adduction force to the forefoot while the ankle is in plantar flexion, and it can cause a fracture right here. This is known as the Jones fracture, right? High incidence of non-union due to poor blood supply, unless they have surgery. So everybody who has a Jones fracture is getting surgery. No, I know it says poor blood supply. I have not seen or heard of a lot of instances of avascular necrosis in this area, which is why we don't talk about it at that stage, right? I'll let Major Davalos tell you next semester in ortho if he's ever seen it. I haven't, and I haven't heard of that. It's not a common area. But Jones fracture, base of the fifth metatarsal, they need surgery. Okay. Typically going to be a transverse, could be oblique, but right in that area there. Because look at the picture up here. Look at, I mean, there's still blood supply coming in from other areas, so I think that's why avascular necrosis is not super common, but they need to surgery on that. What happened here? Accidental amputation. Yeah. Traumatic amputation of the first, second, and third toes. No idea what the story was behind it. But this is what they'll do. If the patient brings the body part in with them, they will place them kind of where they're supposed to be, and they will take the x-ray. Some patients will bring in something else. Like, I cut the tip of my finger off with a saw. Here it is. On ice. Because they somehow think that you're going to be able to magically reconnect it and make it better. Like, it's not a tooth. Can't put it in milk and make me put it back in, right? So, yeah, amputation. All right. In the presence of a nail bed injury, you suspect it to be an open fracture. This is what's called a tuft fracture. So it's a fracture of the ungual tuft, right, which is what holds the nail onto the foot. You can have that on the fingers as well. The key thing with tuft fractures often is people forget to treat it like an open fracture and put the patient on antibiotics because they don't think of that. But the odds are there's probably a nail bed injury, there's probably blood under the nail. That means it's an open fracture, treated appropriately. It's definitely comminuted. Would everybody agree? Multiple pieces. What's going on here? Do you remember? Gout. All right. Take your time. Can't use the notes because the notes are generalized. Go through your systems. All right. So first I'm going to ask, what are these? Good. Sesamoids, not an abnormality. What I have here is a complete second metatarsal fracture. Because this is an oblique x-ray, I would probably say transverse, right? Because it looks like it's kind of straight across. It's not at a large angle. And then I also have an incomplete fracture, transverse, of the third metatarsal. See how it comes in and it stops about 3/4 of the way over. Got it? See it? Yeah? So everything you're seeing down here, yeah, it's joint spacing, it's that oblique. It makes those joint spaces pop just a little bit more. Yeah. So good question, right? So like, what is this? Is this a fracture here, right? So it kind of goes into the tarsal. That's what he was asking. I think that is a valid question for you to ask yourself, and that is why we get 3 pictures of the foot every time we do it. So now what would you do if you were in the clinic on this? Or if I give you 3 pictures on the exam, because some of them you may need 3 to help figure it out, right? You would go, I have a question about this tarsal right here. Well, now I'm going to go to the other view, and I'm going to look more closely in that area to see if I see that fracture. Do I see a break in the cortex? If the answer is no, then I know that it's possible that this could just be joint spacing. So if my other image doesn't show a fracture, it's just joint spacing on that picture. And that's where you have to use all the pictures together to get your answer. So I like that you're thinking that, because that's a good thing to think. And then in real world, and if I gave you this picture on the test, which it won't be this picture, I would also give you that dorsal plantar view to be able to distinguish that that is not an abnormality. Okay? What's that? I heard somebody say it. Heel spur. Not a fracture. Heel spur. Why do we have heel spur? It's likely this patient has a history of chronic Achilles tendonitis, right? And so what's happening is the Achilles tendon kind of comes down, and some of it kind of loops into this area too sometimes. Comes down and kind of loops, and so the body is starting to create calcifications or a spur to try to stop it from hurting because it's tired of the inflammation. So, we just talked about it. What's it called? Jones fracture. What do they need? Surgerization. That's right. Guys, you did it. Block 1 of radiology. MSK done. What questions do you have? All of them, right? All of the questions. Oh, can you tell me 50 things for Friday? Right? All right. So again, just real quick, and I'll rehash this again on the review, right? Couple of things. Remember to read what I'm asking. Not every question has pictures. So read the question. We'll figure out what I'm looking for. Is it initial study? Is it study of choice? Is it just find the abnormality? Is it what's the disease? Like, what am I asking you for? Then read your answer so you understand how I'm asking it, right? Is it just simple, like third, fourth, and fifth metatarsal fracture, and it doesn't like break down the oblique versus transverse versus comminuted versus, whatever? Great. Then if I don't see any of those descriptors, I know I'm not going to spend any brain power trying to figure out, is it oblique, is it transverse? Know what the answer choices are so you know what you need to be looking for. Then go to the question, okay? If you zoom, I have not heard complaints on this. This is just my paranoia brain talking, okay? You will be able to zoom with your fingers or control plus to control minus on this exam. My class only for block 1 and block 2. That is not authorized on, I don't think, any other course unless they specifically tell you. You are allowed to do that for this course. If you do, especially for those of you with touch screens, highly recommend after you zoom, when you zoom back in and you choose your answer, I would scroll up just a little bit to the previous question you already answered. Make sure you didn't accidentally change your answer, right? Because you guys don't normally have tests where you're all over the place. I have yet in a year and a half of teaching this, had anybody like come to me, like, when they come to review the test, be like, oh, I did that, but my paranoia brain just says, like, I can see myself doing that. So just make sure you just double check. You're like, nope, that's still what I want. Okay, moving on, right? Time management's important, okay? You'll have your 75 minutes. Really, it's 70 minutes plus 5 for technological issues or whatever. Use your time wisely. It's really easy for the time to get away on these ones because you sit in the weeds and you're looking at the pictures and you don't want to miss anything, which is why I say look at the question and the answers first. It will probably speed you up a little bit because I can watch your faces, and for those that don't, sometimes they'll spend all this time looking at it, and then they get down and they look at it and they're like, oh my God, I just had to know it was an MRI. Like that kind of thing, and it frustrates you, and then you kind of spiral, right? Test average for this one is usually pretty good. Okay. There'll be a lot of the stuff in the intro slides. There'll be first orders, there'll be second orders. There will be at least one normal x-ray answer. There'll be at least one normal x-ray, at least one. So if you go through your test and you didn't answer a normal x-ray for any of them, you should probably go back and look at those ones and maybe pick normal for at least one of them. Seen it happen, guys. I sit here and I've seen my life. Oh, I thought you were tricking. I'm not tricking you. There will be at least one question, not very many, because it's very a task on the system. There'll be at least one question, 2 at most, where your choices are 5 pictures, and you read the vignette, and you have to pick the picture that goes along with the vignette or where the injury is. Okay. Every question, our minds in the test, every question that's supposed to have a picture at the end of the question should say, image should be present, or 3 images should be present, or 5 images should be present, or whatever. So you know that you have what you need, right? So everyone will have that. If it doesn't say it, it's not supposed to have a picture, okay? So just so you're tracking that, and I'll remind you that on test day. So that way, if you have pictures that don't load, you can kind of raise your hand, and sometimes that will happen. But usually the answer is go through and like do all the ones without pictures first, and give time for the system to load these things. I wish we had better bandwidth and a better system to pull these things up, which means use a website, don't use the app. The app will suck and it will possibly crash. Yes, ma'am.
Quick question, sir.
Yeah.
Will we have a normal and then an abnormal like we do here in the lecture, or just an abnormal?
You will have a picture.
Okay.
I don't want to say you'll have a normal or an abnormal, so it depends on the question, right? You will not have comparisons like we have here. The comparisons here are to help you pick out the abnormalities while looking at the normal. But on the exam, you will just have the picture, because in clinic, you're just going to have the patient's picture. You won't have like a normal for them to compare it to in that aspect. Yeah. Yep. What else? Questions right now? Okay. TBD for tomorrow. Your class leader and I talked. There's some Housekeeper, you gotta figure out with your schedule. He will let you know what tomorrow looks like as far as when is the lab and when is the review, potentially, if that's what you guys decide how you wanna do it. But other than that, I'll stay up here for a few more questions afterwards, and have a good day, guys. I'll see you down.